Hello, good afternoon. This is Professor Nick from Brooklyn, New York. Today is Sunday, March 6th at 2 p.m. Sunday, and I have some time to discuss with you some GI notes for PAMP board examination. We have, we have a couple of slides for other GI issues. If you have any questions or comments, you can reach me at my email, which is nickm like Mary D like dog the number 1 at gmail.com. Let's go to the first slide. Here on this slide we will talk for diarrhea. Let's talk about antibiotic-associated diarrhea. Although clindamycin may be associated with highest incidence of antibiotic-associated diarrhea, and C. diff is also one of the highest incidence. Potentially any antibiotic can cause diarrhea. We can see in the stool that there is blood and white cells that can be presented. Also, it's usual after several days or weeks after the start and antibiotic to have a diarrhea, the patient to have a diarrhea. The best initial test, this is a stool C. diff toxin test or PCR. And the best antibiotic as an initial therapy, this is metronidazole. The next step of management to switch is oral Vanco or fidaxomine. Let's go to the next slide. This slide discusses a clinical vignette. 75 years old man is admitted to the hospital with pneumonia. Several days after the start of antibiotics, he began to have a diarrhea. It was noted that he has a C. diff toxin positive, and he was started on metronidazole, which led to a resorption of the diarrhea over a few days, a resolution of the diarrhea in a few days. 2 weeks later, the diarrhea recur and the C. diff toxin is again positive. And the question here is, what is the most appropriate next step of management of this patient? And you can see the answers are A, retreat with metronidazole orally, B, use vancomycin orally, C, sigmoidoscopy and treat with if pseudomembranes are found, D, IV metronidazole, E, wait for stool culture, and F, intravenous vancomycin. The right answer here is A, which is in case of the recurrent episodes, the explanation is in case of recurrent episodes of C. diff, diarrhea, we need to treat with another cause of metronidazole. IV metronidazole is used only if the oral therapy cannot be used, such as in the patients with adynamic ileus. Stool is never cultured for C. diff because of simply will not grow in culture. And we have here a clinical tip. IV vancomycin is always the wrong answer for antibiotic-associated diarrhea, since it will not pass the bowel wall. So remember this, IV Vanco does not pass the bowel wall. Let's go to the next slide. Slide number 4. We have a clinical tip, which is switching to oral vancomycin or fidaxoximine is the answer when the case does not respond to metronidazole. So if the patient does not respond to metro, we switch to vanco, oral vanco, or fidaxomine. On the right side of the slide, on figure 9.9, we will see antibiotic-associated diarrhea algorithm. First, the diarrhea on the top is the diarrhea after antibiotic use, questionable. If C. diff is positive, then we consider alternative causes or treat with metronidazole. If there is improvement, we continue the metronidazole till the end of the course, or if there is no improvement, we switch to oral vanco or fidaxomine. Let's go to the next slide. This slide discusses another clinical situation, which is malabsorption. Celiac disease is one of the most common types of malabsorption and can be presented in adult patients. Chronic pancreatitis is a very similar presentation with fat malabsorption. Rare causes for fat malabsorption are tropical screw and Whipple disease. All of these are present with steatorrhea, defined as stool that it is oily, greasy, floating, and foul-smelling. Okay. All forms of fat malabsorption presents with deficiency of fat-soluble vitamins such as A, D, E. So vitamins A, D, E, and K. They can be all presented in the following. There is nothing clinical to distinct tropical sprue from celiac sprue, which is gluten-sensitive enteropathy. Here there is, on the lower part of the slide, there is a clinical tip which states that celiac disease gives dermatitis herpetiformis in 10% of the cases. On the right side of the slide, there is another clinical tip that vitamin B12 needs an intact bowel wall and pancreatic enzymes to be absorbed. On the table on the right upper side of the slide, we'll see that there is a 3 types of deficiency, and every one of them has a different. So there is deficiencies and their manifestations. So vitamin D, the manifestation deficiency, there is 2 manifestations: hypocalcemia and osteoporosis. Vitamin K deficiency, there is a bleeding and easy brewing. And for vitamin B12 deficiency, we have anemia, neuropathy, and hypersensitive. So we have once again anemia, hypersegmented neutrophils, and neuropathy. Let's go to the next slide. Here on this slide, which is slide 6, we'll talk about hiatal hernia. This is basically protrusion of the upper part of the stomach into the chest, generally caused by obesity, weakening of the diaphragm. Frequently is associated with heartburns, chest pain, and dysphagia. Symptoms can be undistinguishable by GERD. Diagnosis is made by endoscopy or barium study. The best therapy for this is weight loss and PPI. But if the symptoms persist, surgical correction such as Nissen duplication is performed. Rarely, emergency surgery can be done for gastric volvulus, obstruction, strangulation, or perforation. Paraesophageal hernia is also most likely to need surgery, endoscopy, so to exclude cancer. Let's go to the next slide, slide number 8. This slide, we can see on figure 9.1, sliding hiatal hernia animation. Here the most important and alarming symptoms which are indicated for endoscopy include weight loss, blood in the stool, and anemia. And this is the end of the part 1 of the GI notes. Once again, this is Nick Nicole. I'm from Brooklyn, New York. Have a good afternoon. Thank you.